Let me begin by just saying thank you for joining us. We really appreciate everyone being here. My name is Katira, and I am leading our new Health Promotion and Wellness Department at the 92nd Street Y, soon to be known as Spark Your Health Talks and Programs. Over the next several months, we will be busy at work cultivating meaningful and educational health programs to support a renewed and continued interest in self-care, caring for those around us, and caring for our community. Our cancer screening discussion today is the first in a four-part Cancer Awareness Roundtable Series, taking place over the next 4 months. So more information to come on those. Lastly, we have a wonderful talk coming up as well on Tuesday, March 1st with AARP and authors Stephen Perrine and Heidi Skolnick to discuss the power of nutrition and protein timing when keeping off weight over the age of 50. I will send more details on that talk in the chat as well. Should you have any questions during the talk, please enter them into the chat. And we do have a lot of information to get through today, but we will do our best and attempt to answer as many questions as possible. For any questions that we cannot get to, I will be recording those. And then when we repost this recording up on the website, we'll have those questions with answers for you. So everything will eventually get answered for you today. And again, this is a collaboration, this talk through the May Center for Health, Fitness, and Sports, and as well as the Himan Brown Senior Program. So I'm going to turn it over to Elizabeth Tarr of the Himan Brown Senior Program to introduce our speakers today.
Thanks so much, Katara. Hi, everyone. Good morning. Thank you so much for joining us today. I am going to introduce our two speakers. I will introduce them in the order in which they will be speaking. And I just want to say a really big thank you to both of them, because I know how hard it is to find the time to educate people, but it's so important. So our first speaker will be Karen Schmitt, and Karen is an amazing nurse who I have had the pleasure of working with for over 25 years. Karen is, for me, not only a wonderful nurse who takes great care of people as individual patients, she's also a wonderful public health expert. She is the director of the Cancer Services Program in the Division of Community and Population Health at the New York Presbyterian Columbia University Irving Medical Center. She's also the co-director of community outreach and engagement for the Comprehensive Cancer Center. And Karen has helped work with me to help women learn about taking care of themselves in all aspects. So she's going to talk to us today about screening for different cancers: breast cancer, colorectal cancer, lung cancer, and how guidelines are established and how guidelines change. Sometimes we know things change from year to year and we don't really understand why. So Karen's going to explain all of that to us. And then immediately after Karen speaks, we are going to hear from Dr. Elise Desperito, who you can call Dr. D. So Dr. D is a board certified diagnostic radiologist. She specializes in breast imaging. She is the director of the breast service at Columbia Presbyterian Radiology. And she is also the vice chair of education. And I was learning about her and reading about how much she not only wants to take care of her clients, but she also really wants to educate new radiologists to be the best radiologists they can be and give their patients the best information possible. She's also a member of the Radiological Society of North America and the New York Rodigan Ray Society and the Society of Breast Imaging. So first we're going to hear from Karen, and then we will hear from Dr. D, and we will take questions intermittently. Thank you both so much.
Thank you for that very kind introduction, Elizabeth. Elizabeth and I have a mutual admiration society. She's the best person and social worker I've ever met. Today, I'm going to talk to you a little bit about the guidelines for screening because they can be confusing. They change with some frequency, and it's sometimes hard to know what we should be believing and not believing. So I just want to talk about the differences in prevention. So primary prevention is when we can do something to stop cancer from occurring. And there are a number of things that we can do. We can avoid tobacco use and secondhand smoke, avoid sunburns. We can receive HPV vaccinations, and we can receive hepatitis B vaccinations. I can also say here that if we do colorectal cancer screening and we have a finding that's called a polyp, if the polyp is removed, then that area will not develop cancer. So on some level, colorectal cancer screening can be thought about as a prevention. Secondary prevention is also called screening early detection. So the secondary prevention things that are done are pretty obvious to most of us, that breast cancer screening is done with a mammogram. Cervical cancer screening is done with Pap screening in conjunction with HPV testing. Colorectal cancer screening can be done by fecal-based testing or colonoscopy. Prostate cancer screening, although it really needs to be discussed with your doctor first, can be done using the prostate specific antigen that most of us know as PSA, and also a digital rectal exam. Low dose computed tomography, or CT scanning, is done for people who are current tobacco smokers or people who have a certain amount of tobacco smoking history. To talk a little bit about the guidelines, I just wanted to start with where we have been. So in the early 30s, in the 30s, 40s, and 50s, there were public campaigns that advocated early detection for cancer. And this was supported at the time by the American Society for the Control of Cancer. However, these strategies were based on an intuitive thought that if we found cancer early, we could cure it. In the 60s and 70s, the medical profession began seriously questioning the use of intuitive thinking and began rigorous testing or research on the effectiveness of the procedures that are done for early detection. And these were done through what's called randomized clinical trials. The United States Preventative Services Task Force, or USPSTF, played a critical role in the move away from intuitive thinking and replaced how they thought and how they would publish their guidelines with using evidence-based or research medicine. And these methods, the methods that were used were to look at the overall risk and benefit of any given screen. So for example, there's a typo. The Pap test was developed by Papanicolaou in 1923, but it wasn't until the 60s, after a lot of testing was done on what the harms and benefits of Pap screening were, that the American Cancer Society began supporting it as a good modality for early detection. Similarly, mammography methods were developed in the 60s, but the American Cancer Society only began promoting it and supporting it in 1976. Okay, so today, screening guidelines, as I said, compare the benefits and the harms of any screening test. It's based on research findings, and then the guidelines will either recommend or reject that type of screening, or aspects of that type of screening, or age groups for that type of screening, based on what is found in research. And so these benefits and harms for screening can also be further categorized for different groups of people. So what we'll see as we go through the different guidelines is that the recommendations can be aimed at specific groups or specific age groups. And since research in the area of cancer screening tests or modalities is ongoing, we will see now and again that there are changes in screening guidelines. And we often see, on the front page of the New York Times, mammography no longer recommended for, and everybody gets crazy. But when we read the fine print, what we are seeing is either better research that replaces old research, or more research that keeps pointing in the same direction. And the different groups that publish guidelines are the following: the American Cancer Society, the USPSTF, as I've said, also the American College of Radiology, the American College of Obstetrics and Gynecology, and the Society of Gynecological Oncology. The National Cancer Institute, or NCI, used to publish guidelines, but they stopped doing that now, I think about 10 years ago. So we start with breast cancer screening. So if we look across, if we look at the second column, we see that screening is broken down here by age, right? But when we look over to the last column, we see some descriptions that talk about different ethnic or racial groups. So for example, the American Cancer Society and the USPSTF do not recommend any kind of screening between the ages of 30 and 39. But what the American College of Radiology is now suggesting, and Dr. D will go into this more with you, is that a woman's individual risk for breast cancer should be discussed at age 30, and a plan for those women who are at higher risk for breast cancer should be initiated at that time. Okay, so then we go down to 40 to 44, and then you see that the American Cancer Society is saying that women should have a discussion with their doctors to decide whether or not screening should be initiated at age 40. The USPSTF does not recommend it, and the American College of Radiology is saying that it should be recommended for African American, Hispanic, and oh gosh, another typo, my apologies, Asian women. Another typo, good grief. It should begin at 40, as the peak incidence in these age groups tend to be in the years between 40 and 49. Okay, so then we get down to more recent things that we've heard, that from 45 to 64, the American Cancer Society is recommending annual mammographic screening, whereas the USPSTF is not recommending it at that age, but recommending that we initiate screening at age 50. Okay, and that screening should be every 2 years. The 65 plus years, there's annual screening every 2 years for ACS, but not for USPSTF. They are saying, however, that women can stop screening USPSTF at age 74. So what they're really saying for the 65 plus group is to have a discussion with their physicians as well. And let me just be clear that the guidelines tend to be focused on people who are at what we call average risk for the development of cancer. And average risk is really kind of defined in a strange way, in that it means you're not at high risk. So if a woman, for example, has a family history, especially a first-degree relative, a mother, sister, or daughter who's developed breast cancer, that would put her at high risk. If she's had 2 or more second-degree relatives, a grandmother, an aunt with breast cancer, then she would be considered higher risk as well. Okay. For cervical cancer screening, we've got the U.S. Preventative Task Force, but we've also got or American Cancer Society, but we've also got ACOG and SGO, the 2 that I mentioned earlier. And what we're seeing is that women should begin cervical cancer screening between ages of 21 and 29, according to USPSTF, but not start until age 25 to 65 per ACS. And the screening tests are varied for cervical cancer screening. The high risk HPV test is a test that can be done on certain samples, that the same sample that's done with a pap smear. Okay. And the 3 different ways of screening, and based on who's recommending, all fit into a certain category. So category 1 would be pap only. Category 2, pardon me, category 2 would be a pap smear, that the ones that we've all, or I've had when I was much younger before HPV, or pap plus HPV together, which is called co-testing, or HPV only. So HPV only is usually recommended every 5 years, as is pap with HPV co-testing, but pap alone would be recommended for rescreen every 3 years. And it's important for women to remember to find out from their doctors what kind of cervical cancer screening they are getting. Because some doctors will co-test, do pap and HPV at the same time, and some doctors will do a pap, and if the pap's abnormal, then they will send that specimen for additional testing with HPV. Okay, colorectal cancer screening. Colorectal cancer screening can be done a number of ways, but the 2 most common ways that it's done, which are fecal-based testing, having a specimen of stool and sending a smear, if you will, from that specimen to a lab to be tested, or colonoscopy. And colonoscopy, from those of you who have had it, know that is something you'll never forget, because there is a couple of day preparation that you have to take in order to cleanse the colon, so that when the colonoscopy is done, everything can be visualized very easily. In May of 2021, the USPSTF recommended that colorectal cancer screening should start at age 45, and not what it previously was at age 50. Okay, and this now again, and the American Cancer Society was right behind them. What this is telling us is that what the research has shown is that that a lot of colorectal cancers are being diagnosed in people younger than age 50, and they call it early age colorectal cancer. One of the ethnic groups that is especially affected by this are African Americans, but others are getting it younger too. So the guidelines just changed to decrease the age and increase the number of people who should be getting colorectal cancer screening. In general, fecal-based testing has to be done every year, unless someone uses Cologuard, then it's every 3 years. And colonoscopy, if all is, and colonoscopy of everything as well, does not have to be done, but for every 10 years. Okay, now prostate cancer screening is one of those cancer screens that is iffy. And the reason that it's iffy is that the PSA test does not have the same sensitivity and accuracy as a mammogram or a pap smear. And what can happen is the PSA can rise in the blood in men who have enlarged prostates, as well as in men who have prostate cancer. So there's a lot of discussion always about prostate cancer screening and who's it best for. So the prostate cancer screening is done with the PSA test, but it is also done, as I said earlier, with a digital rectal exam. And overall, it is recommended that men at the highest risk for developing prostate cancer, those who have family history of prostate cancer, need to have a discussion with their doctor and could possibly start screening early. If we look at, and this is through the American Cancer Society, then if we look at age 45, The American Cancer Society is saying, especially in African-American men who have the highest rates of prostate cancer. And then if we look over to the right, we're seeing that the U.S. Preventative Task Force is not recommending, okay? So as we go down, what we are seeing is that the use of the PSA test, because there is the risk of harm, meaning a PSA test would be abnormal, it would be positive. There is no cancer, but a man may have to go through, may be recommended to go through biopsy to check, and that biopsy in and of itself would be doing harm. So the best thing for men to be doing is really to know their family history for prostate cancer and have a really good discussion with their doctor about whether prostate cancer screening is okay for them. Now, in the cases of men who have, oops, I'm sorry. All right. So anyway, this is what I just talked about. These are the issues that we find with prostate cancer screening. And I'll just jump, and my screen has locked. There we go. And one of the things that would result in a recommendation for prostate cancer screening would be if the man has symptoms of prostate cancer. And that would be problems urinating, blood in the urine, trouble getting an erection, pain in the hips, back, chest, weakness or numbness of the legs, feet, or a loss of bladder or bowel control. Those symptoms would be related to prostate cancer. But as we can see with pain in the hips, back, and spine, for example, that can be related to a lot of other things. So again, it is very, very important for men to have good conversations with their doctor, and they can see a specialist and discuss it even further than with their primary care doctor. Lung cancer screening. Okay, lung cancer screening is really for people who are age 50 to 80, who have a 20-pack year smoking history. And there's a program that we use to calculate what a 20-pack history means. So if a man is a current smoker, or if a person is a current smoker, or if they have quit within the past 15 years, but they were 20-pack year smokers, those are the people who should be screened. And the screening is often every year using the low dose lung CT. Okay, and screening should end if the person then reaches that they haven't smoked for 15 years, or if the screening, if finding an abnormality in the CT scan would not prolong their life. And so we're really talking about someone who maybe have other diseases. They would not be a good candidate. It would not be safe for them to have an operation. And so why would you be looking for something if you can't really treat it? Is kind of the thinking there. So what should we consider? That the guidelines are the outcomes of scientific study and review, and that we should expect that they get changed. The best way to be informed is have a discussion with your doctor. For those of you who are website freaks like me, the best websites to keep up with are both the American Cancer Society's website and the USPSTF website. And with USPSTF, they rank their recommendations with letters. So you're really looking at letters A and B as the ones that are either recommended or recommended with caveat. And just for a little promotion of one of our programs, if any of you have yourselves or have friends or family who don't have health insurance, We have a free screening program for breast, cervical, and colorectal cancer at New York Presbyterian. And the number to reach us is 212-851-4516. And thank you so very much for your time.
Thank you so much, Karen. So we did have a question come through. So this is back to the beginning of your presentation when you were talking about the removal of polyps with colon rectal screening. And you mentioned, you know, if it was removed, there would be no cancer. So someone is asking, but could that cancer still develop later?
No, what could happen though is that you have other polyps. Oftentimes, people who develop polyps don't just develop one or two. And there are certain diseases that are hereditary where people develop multiple polyps. All polyps are not precancerous, but all polyps, and precancerous meaning they're the type of polyp that would later on become cancer. But all polyps do need to be removed and tested in pathology to determine if they are the kind that would likely become cancer and the kind that would not. So if the polyp is removed, it's what would be causing the cancer. So that's why that cancer wouldn't happen where that polyp was. Okay, but people can develop other polyps in their lifetime, and that's why if, for example, if someone had a colonoscopy and a polyp was found and it was tested and it was the kind of polyp that would progress, they're called adenomatous polyps. That person would then have to have a colonoscopy every 3 to 5 years.
Thank you so much.
Instead of every 10 when we said it was earlier, when we said it was screening and it was normal.
Perfect. Thank you so much for clarifying that. So with that, I'm going to hand it over to Dr. Desperito. And so I will add her into the spotlight and let her share her screen. Karen, thank you so much again. Great information.
Hi, good morning, everyone. I'm going to share my screen, so just give me a sec here. There we go. Okay, very good. Good morning, everyone. Thanks so much for coming to listen to our presentation today. I don't know if I'll be able to get through my full presentation, but we'll see how well we do here. I'm just going to check the time, 10:28. So the areas that we're going to talk about today are understanding risk factors, disparities in breast cancer care, and the biology of breast cancer and screening guidelines, which Karen has already talked about in a thorough way, but more than just breast cancer. So a lot of territory to cover, but hopefully this will help explain some things that for many people, even me who does this every day, can be confusing. All right, let's see if we can go forward here. Good. So breast cancer is the most common non-cutaneous malignancy. In other words, that it's the most common cancer other than skin cancer that we get. And it's the breast cancer is the second most lethal form of cancer among women in the United States. In other words, it's the second most common cancer that women die of. So right now, breast cancer currently affects more than 1 in 10 women worldwide. This number has increased since 1975. Prior to 1975, or around then, when we really started doing kind of comprehensive breast cancer screening, it was 1 in 11, and now it's about 1 in 8. So 40,000 women die from breast cancer each year. And so that's why this is important to talk about, because if you do get cancer, we don't want you to die from it. We want to be able to treat it, and we want you to go on and live a happy and healthy life. So hopefully by the end, there'll be some ways that you'll come away from this presentation knowing, okay, this is what I can do to help myself. So what can we do as women? Most importantly, we need to take care of ourselves. And although there are many different recommendations for when people should start screening, how often they should screen, as a radiologist, I'm a member of the American College of Radiology, and I work very closely with our breast surgeons and our breast oncologists. Our societies, the people who do this work all the time, really do recommend that you start, a woman begins getting her first mammogram at 40 if she's of average risk. And I'm going to talk a little bit about that. So not only do we need to take care of ourselves, but educating our friends and family about when to get this care, this preventative care, is important. So what do we know about Black women and those of Ashkenazi Jewish descent? We know that they have a higher risk of breast cancer. And right now, the recommendation is that every woman, when she turns 30, gets a breast cancer risk assessment, but particularly Black women, and particularly women of Ashkenazi Jewish descent, get this risk assessment. What that means is, if their risk is identified as higher, we would potentially begin doing mammograms for her before the age of 40. We might do ultrasounds for her. We might do MRIs for her. So there's a very different way that we care for women who are at high risk than for average risk. So knowing your risk is important. So this is another way we can educate friends and family and grandchildren and friends of grandchildren about how they can get the best care. So for African-American women, what do we know? 42% of African-American women are more likely to die from breast cancer than white women. They have a 2 times increase of what we call triple negative cancers, which are aggressive cancers. And I'm going to talk about this a little bit more later on. And they're less likely to be diagnosed at an early stage. And what that means is that Black women are less likely to get their screening mammograms at when they should be. And oftentimes this is a result of many factors: accessibility, fear of our healthcare system, just not having those resources available to them. With Hispanic women, although Hispanic women are less likely to get or die from breast cancer, they are more likely to die from breast cancer than any other cancer. They're more likely to be diagnosed later with breast cancer. And again, this is often that we find that our Hispanic women are not getting the screening that they should be getting. And they're more likely to die within 5 years of being diagnosed than white women, again, because they're not getting that early screening and we're not able to diagnose that cancer as soon as we would like to. So since 1990, there has been progress, and this is so important, that 23% of African Americans, there's been a decrease in death from cancer, 29% in Hispanic women, and 39% in women. So when people say, oh, I don't want to get a mammogram, it's not that hopeful, or why should I get a mammogram? We know that women getting a mammogram saves lives. And so it's so important that we get them ourselves, and we encourage our family and friends to get a mammogram. So these are the kind of areas that I'm going to focus on. What does risk mean? And I know Karen talked a little bit about this, so I'm going to go through that quickly. We're going to talk a little bit about the biology of breast cancer, disparities in breast cancer care, and some screening guidelines. All right, so we're going to start here. Major risk factors. So this is always something that is important to think about. I think no matter what gender you are, we can stress about the things that we can't change or focus on the things that we can change. There's no sense stressing about our being women. We're not going to be able to change that. There's no sense of stressing about getting older. We can't change that, although many of us would like to. So we're going to think about what are those areas that we can focus on, where we can decrease our risk. So what can't we change? We can't change our sex. We can't change our age. We can't change the family we were born into. So we know that the chance of being diagnosed with breast cancer increases with age. It's a kind of disease, a cancer of aging, just like prostate cancer is for men. And age and sex are considered important risk factors. And I know there was a question that I was sent, I don't know, from Katira, someone asked about men's risk of breast cancer. We know it is much less, 1 in 1,000 versus 1 in 8 for women, but men do get breast cancer. About 1% of the breast cancers that we diagnose in the US are male breast cancers. So this is important too. If a man feels something in his breast, or if he has bloody discharge from his nipple, these are all signs that he needs to go to his doctor and have that worked up, so we understand why that's happening. So again, what can't we change? Family history. So one of the most widely recognized breast cancer risk is our family history. And what does that mean? So when we talk about the breast cancer risk and elevating someone's risk, it's in a first degree relative. And so what's the definition of a first degree relative? A first degree relative would be your mother, would be your sister, or it would be your daughter. So if you have a great aunt who had breast cancer, certainly that's something that when you have your risk assessment is considered. But a first degree relative is really what we focus on in terms of determining if that your risk puts you in a high risk category. It's important to differentiate between family history and genetic, or your genes. If you have the gene for breast cancer, this is very important. Having a family history of breast cancer does not mean that you have a genetic mutation for breast cancer. It's absolutely different. So what do we mean by a genetic mutation? Many, I'm sure, have, if you listen to any kind of news or read the news, or you're well informed, you've heard of BRCA BRCA1 gene or the BRCA2 gene. These are well-known genes that influence or affect our risk of breast cancer. 5 to 10% of the breast cancers that we diagnose are hereditary, are due to one of these genes that a woman has. And so how do we figure this out? Well, this is figured out by evaluation of a patient's gene. And this is why if you go to see a specialist who looks at your risk and your genetic profile, this is not something they can determine by looking at you. They need to draw your blood or look at your saliva, and this is evaluated in a very particular way. Now, what's also important is that they are able to now, with our much better understanding of the human genome, identify other genes that elevate a woman's risk of breast cancer. And you can see on this blue part of there's lots of a bunch of letters there, nothing that you need to remember, but it's just to emphasize that with the science over the past 10 to 20 years, not only do we know about the breast cancer 1 and breast cancer 2 genes, but there's other genes that do affect our risk of breast cancer. So the BRCA1 mutation, this is important. This is important to understand, particularly with Ashkenazi Jewish women, because that's the highest rate is among women. 8.3% of the BRCA1 mutations are identified in women of Ashkenazi Jewish descent, followed by Hispanic women, non-Hispanic white women, Black women, and Asian women. So we do see this mutation in all of our different cultures, but most particularly in our Ashkenazi Jewish women. And what does this mean? This means that a woman who has this particular mutation has a 70% risk of getting breast cancer in her life versus someone without this mutation, which is about 12%. And again, this is when we educate ourselves about this. Oftentimes, this is where the fear sets in. Oh, I don't want to get the genetic testing. What if I do have the gene, and then I'm just going to be so upset that I have a lifetime risk of 70%. So certainly that's an understandable response. And oftentimes when I have these conversations with women, my response is, well, if we understand what your risk is, then we can help take care of you in a different way. And what that means for us in imaging is that we might do a mammogram and an ultrasound, or might do a mammogram and an MRI, or we might make sure that we're taking care of your children at an earlier age. So from my perspective, educating ourselves about our risk is very helpful. So then we can advocate for ourselves and our doctors can advocate for us to get the care that we need. So do we want to, does anyone have any particular question, Katira? Has anyone put anything in the chat box? Because I know that's a lot of information for a short period of time.
Yes, at the moment, we do not have any specific questions coming up.
Okay, so I'll just carry on and we'll keep going. Okay, so this is a confusing slide, but it's not meant to terrify people, although what goes on inside of our cells is truly wondrous. But this is a pictorial of a cell. And right here, I'm using my arrow to show you a receptor. So on the outside of our cells, we have these receptors, and it's a way that our cells communicate with the outside environment. This becomes very important when we talk about breast cancer cells. So something that I mentioned before, the aggressive forms of breast cancer called triple negative cancers are less responsive to standard treatment. And we have identified these more aggressive cancers in African American and Hispanic women particularly. So what does this mean? All right, so going back to a pictorial triple negative. So let's talk about, and I'm simplifying this. So if there's any biologists in the room, I apologize for my simplification, but this is kind of looking at a very particular area of kind of receptors and hormones. So on a cell, we have many different types of receptors. In breast cancer, we look at three very particular type of receptors: estrogen receptor, progesterone receptor, and something called human epidermal growth factor receptor 2. So these three receptors are a way that that cell communicates with the outside world via those hormones, through the estrogen hormone, the progesterone hormone, and the human epidermal growth factor receptor, or human epidermal growth factor hormone. Okay, so what happens? So when a triple negative cancer, which you see on the right, that triple negative cancer does not have those three receptors. So triple negative means it's negative for the estrogen receptor, it's negative for the progesterone receptor, and it's negative for the human epidermal growth factor receptor. So what does that mean? It means that many of the medicines that we have to help kind of destroy that cancer cell, kill that cancer cell, work through this receptor system, and they block those receptors, and they prevent the hormones from getting to the cell and making that cell multiply and increase. So for women who have the triple negative cancer, because they don't have those three receptors, the medicines that we have to help destroy a cancer don't work because they don't have the receptors. And so those cancers are much harder to treat. So what happens, you can see here, we can't stop their growth, that those cancer cells continue to grow and they don't respond to the chemotherapy that we're able to provide for women who do have those receptors on their cancer cell. Now, if you were to have a biopsy, that little bit of tissue that's removed is sent to pathology, and they do very advanced analysis of the tissue to determine these type of things. So again, a pictorial just to help kind of clarify what this means. We have kind of a pictorial of a cell here, the nucleus in the middle. We have those receptors here, and here's our human epidermal growth factor receptor. And that little human epidermal growth factor is coming and telling the cell, okay, cell, grow, grow, grow. Now, without that receptor, okay, this Herceptin, which is one of the medicines our oncologists use, can't block that, can't block those receptors. And so it can't stop that signal or that communication with the cell to grow. And so this is where, when we talk about personalized care and personalized medicine, this is how we're able to personalize. So when a woman is diagnosed with breast cancer, my breast cancer would be different from Karen's breast cancer, most likely. So this is the way The biology is evaluated, your history is evaluated, your family is evaluated, and then that oncologist comes up with a special plan for you to best take care of your cancer so that you can really beat it. So that's a lot of biology there. Any questions, or should I carry on?
Yes, we did have a few questions. One was about, so can you explain, does the risk of getting breast cancer increase with age?
Yes, no question. As we get older, our risk of breast cancer increases. And I have a graph that will come up later in the lecture.
Got it. Thank you. And the other question was about the BRCA gene. I know that you had a chart that showed, the risk is 70%, but they were just asking and kind of asking for clarification that if you have that gene, that doesn't mean you 100% will get breast cancer, correct?
Correct. Absolutely correct. It does not 100% mean that you will get breast cancer. It just means that your risk is higher than a person who doesn't have that gene. And what we do, the doctors who take care of women with breast cancer, we say, oh, this patient has the gene, is positive for this gene. How are we going to care for her? What are we going to do to help make sure that if she does get a cancer, that we diagnose it at a very early stage?
Thank you so much. That is it for now.
Okay, very good. So we'll continue. So breast cancer survival, and this is, important to talk about. I'm gonna go ahead here because. So what can we do to help ourselves? And I think that's really where we have to focus our attention. And there are absolutely ways that you can protect yourself from the risk, decreasing your risk of breast cancer: physical activity, diet, personal health, and obesity, and of course, your choice to get a mammogram. So 75% of breast cancers diagnosed have no hereditary origin and don't necessarily have any particular risk factors. And this can be very upsetting to women because they say, look, I ate well my whole life and I exercised. How could I still get breast cancer? And we're still trying to figure out why that happens. So what are some of the ways that you can reduce your risk of getting breast cancer? And here's a list here, but very simply, physical activity. And we know that physically inactive women have a higher risk of breast cancer. There was a study done several years ago by the Agency for Research on Cancer that 1/4 to 1/3 of cancers are associated with elevated body weight and inadequate physical activity. And we know particularly with African-American women, only about 47% get the physical activity that they need. So why is this important? Well, we know that exercises lowers the estrogen and other growth factors associated with cancer, and that's good. But you may say, well, I don't want my estrogen lower. Well, okay, but we need it in a particular range. We need it within a range of normal. We don't want it too high because that is going to affect all of our body, particularly things like breast cancer cells. Lack of physical exercise. When we exercise, we know it controls our blood sugar. It keeps our insulin down. We don't develop kind of insulin resistance. And so what does this mean? Keeping your sugar intake down of processed sugar is essential, and that's easy for us to do. So rather than choosing a donut, we would choose lots of different things. Some cheese and some celery instead of a cookie type of thing. People who are physically active can be healthier and maintain a healthy body weight compared to people who don't exercise. And this is a shocking when I came across these statistics looking at obesity and breast cancer. I mean, particularly with our Black females, 56, close to 57% of Black women are considered obese. 44% of women in Hispanic women in our country fall within the range of obesity, 32% of non-Hispanic white, and about 11% of non-Hispanic Asian. So we know that obesity is a risk factor for breast cancer. So taking care of the food that we eat and our exercise can certainly help us decrease our risk. Okay, just going on. So there was a study done called the HEAL study, and it was an ethnically diverse study, which is great because, as we know, oftentimes those studies that are done are not ethnically diverse. And those women who had a diet low in calories, low in added sugar, minimal alcohol, and low in saturated fat had 88% lower risk of breast cancer mortality. This is tremendous. So by eating well and exercising, we can certainly help ourselves and decrease our risk. Okay, and here's a complicated pictogram again, but it just goes to show the power of poor diet and obesity and how it has an effect on all cancers, not just breast cancer. So questions, how are we doing? Anybody want to ask me anything?
Yes, we do have a few questions coming in. So the first is, can you explain if triple negative cancer is hereditary? So if someone has it, are the risks of their family members getting triple negative cancer higher?
So that is, we don't know really yet. There's a lot of study around this, but I'm going to say no, but that could change next year. So we're still trying to understand that hereditary part of the triple negative cancers.
Got it. Yeah, a lot of research is still ongoing, so that makes sense. The next question, or maybe more of a comment, is that she mentions a book by Dr. Lee, What Your Doctor Didn't Tell You About Breast Cancer Claims, and that estrogen levels must be close to your level of progesterone. So I guess just wanted to hear your thoughts on if we agree with that, if that's medically sound information.
So I apologize because I've never read that book. What's that book called?
It's called What Your Doctor Didn't Tell You About Breast Cancer.
Okay.
By Dr. Lee.
Tell you. Okay, so I hesitate to comment because I've never read the book, and so I don't, taking that, can I say I'll get back to you because I hesitate to answer a question I don't know exactly. So let me just leave it there because I don't want to give wrong information.
No, that's perfectly fine. And then, like I mentioned to everyone at the beginning, we will be posting this recording, and we'll have some of these questions posted as well below the recording. So okay. I think that is it on the question front.
Okay. All right. Very good. So we'll carry on. How are we doing on time? Oh, we got 8 minutes. Yes. Okay. So particularly with Black women, oftentimes it is challenging because of how our healthcare system has taken care of Black women in our society and kind of the systemic racism that we identify in many areas of our society. And so I encourage any of you, if you've never read The Immortal Life of Henrietta Lacks, it's a powerful book about this subject. And if you ever had any doubt about this will really give you a very good and clear understanding. So I think there's sometimes a general fear and distrust of the medical community for good reason. And it's not just with this particular story about Henrietta Lacks, but unfortunately many studies in the past that were done without consent. And so this is very challenging. And I'm just gonna, this is a kind of more, not opinion, but just my perspective on this. This is why it's so important for us to have Black, Hispanic, and Asian women part of our healthcare system in leadership positions, really driving this change so that we can help change the inequities that we all know are not in healthcare, but other areas. So, sometimes people say, have a conversation with your doctor and decide when you should start breast cancer screening. And Karen and I take care of a lot of women who don't even have a primary care doctor. So there's no one to have that discussion with. And this is why education and having the program that Karen runs for our uninsured women is so imperative, because we really want to be able to provide this care for any woman, no matter what the color of her skin, whatever her socioeconomic status is, because we all are at risk for breast cancer. So let's talk about screening mammography a little bit. And for all of those of you who are old enough to have a mammogram, I'm glad you have. Oftentimes the first question for women who haven't, does it hurt? Yeah, it hurts a little bit. Your breast is squeezed. It definitely hurts. Is it tolerable? Absolutely. And so, yeah, it pinches for about 3 seconds and then the compression comes off and you're fine. Why do we have to do the compression? Many women ask me. Well, it's absolutely important for that compression because we can't, for us, people like me, radiologists, to make the diagnosis, we don't want any motion. And so we need to have the breast very still for that image so that we can make accurate diagnoses. So the compression is important. And we do 2 views on each breast, because as we know, a picture is 2-dimensional and our breasts are 3-dimensional objects. So we need those two different perspectives, those 2-dimensional images, so that we can understand the whole breast in its 3 dimensions of it. So when to get a mammogram, and Karen talked about this. So average risk, for sure, beginning at the age of 40, or at least if you have concern about that, have that conversation with your doctor when you're 40. When do you think I should get a mammogram? We know that for Black, Hispanic, and Asian women, that their breast cancer incidence, so the chance that they're going to get breast cancer, is higher under the age of 50 than for white women. And although there are, as Karen had mentioned, the United States Preventative Task Forces and other bodies that recommend beginning screening at age 50, I personally, and the radiologists that we work with and our breast surgeons and our oncologists are adamantly against waiting until you're 50. The last thing we want to see is a woman come to us at 50 and have never had a mammogram before. We also know that women younger than 25 years of age, it's extremely rare to have a breast cancer. And so if a younger woman has a breast complaint, 99.9% of the time, it's not going to be breast cancer. It's going to be something else. So the median age of diagnosis is about 61, with it broken down here for everyone with Black, Hispanic, and white women. And the median age at which women die of breast cancer is about 68 degrees, varying again between Black, Hispanic, and white women. So Karen talked a little bit about this, the different task forces. American College of Radiology is in yellow, American Cancer Society, and the United States Preventative Task Force. And when you compare these 3 particular kind of governing bodies, your percent reduction, personal percent of breast cancer reduction from or dying of breast cancer is reduced by 40% if you have a mammogram between the ages of 40 and extending to 84. So it definitely makes a difference how you choose to have your breast cancer screening, how long, when you start, when you finish. I'm not going to go through that because Karen just did. So here's a nice graph, I think, and important to think about. And over here, it's by age group, by 5-year increments, and the incidence of breast cancer per 100,000 people. So you can see in this 40 to 40, this is not 0. In that 0 to 34, very close to 0. But once you get to 40, this is far from 0. And I think this graph is a nice example of showing that, yes, over time, our risk of breast cancer is increasing. And after we turn 75, it starts to decrease. So for all of you who are older than 75 or 80, your risk is starting to decrease now. So congratulations. So I think this is a nice graph explaining why it's so important to start your screening earlier than 50. I'm going to skip through that. Okay, so we're going to look at a mammogram now. And this is so, so important. Early detection is crucial. I have two different mammograms here. The one on the left shows a small cancer, and the one on the right shows a bigger cancer. And this is the stage at which we want to diagnose a breast cancer. This is why we recommend that you come every year to get your mammogram, because of course we never want to find a breast cancer, but if we do, we want to find it as small as it possibly can. And why is that the case? So this is kind of a 5-year survival rate. And when you talk about localized cancer, this should make everyone feel like I'm going to go out and get my mammogram next week if I haven't. You have a 99% 5-year survival rate if your cancer is diagnosed at a very early stage. This is incredible. This is such a good motivation for why women should get their screening mammogram. And of course, the larger it is, and if it's distant, that percentage goes down. How are we doing on time? Oh, 11. I kind of have to stop only because I have to go cover clinical service. So I'm going to stop sharing my screen, and maybe we could take 1 or 2 last questions from someone.
Absolutely. Thank you so much. We just have one last question to make sure we're respectful of your time. So the question is about, I might pronounce this incorrectly, but getting a mammogram through sonosign. I'm not sure if you're familiar with that technology.
No, I don't know what sonosign is, but so I would have to look that up and get back to you because I don't know what sonosign is. How is it spelled? S-O-N-O-S-I-G-N?
S-O-N-O-C-I-N-E. And I just gave it a quick Google search, so it did come up, but it looks, probably very new. So yeah, that would be interesting to look into.
Okay, so we don't have that technology here, but I'm happy to take a look at it. And I can, again, as Karen said, we could kind of respond to the questions that people have and give you those responses and send them back to you. So thank you so much.
Thank you so much for your time, both Karen and Dr. Desperito. This was absolutely fantastic information. I'm adding back in Karen as well. So we will be posting this on the 92Y website. So if you have questions, there was a lot of information. So if our audience needs to go back and relook at this information, or please share it with your family members. I'm definitely taking away the information that you can't be overcautious. Cautious. It is better to screen and just follow those guidelines and really advocate for yourself with your doctor.
Yes.
So thank you again so much. And yes, and we'll post this on the website soon. And for audience members, I did put my email in the chat. So feel free to email me with any health and wellness topics you'd like to hear about, or if you have any questions.
Okay, very good. Have a great
Thanks so
day.
much
Thank
for spending
you.
the morning with us. Thank you.
You're welcome.
Bye.